side, it makes no difference. Okay. Yes, obviously. It makes no difference where you're looking from, really. But obviously you've got certain things you want to look at when you're looking. So if we describe looking at the front, we're going to look at the head alignment, and for that we're looking at, you know, does it sit squarely on the shoulders? Is it symmetrically equal to left to right? You know, you're going to see these things, and some obviously when you start examining people, you might not say that, but we want you to say, look, we're looking at the head, we're looking where the head carriage is normal, sitting centrally, then we're looking down through the neck, upper fibres of trapezius, which are these big curves you see, out to the apex of the shoulder, and are the shoulders equal and level? Do they sit level from this position? You also, from this level, you can see the anterior bulk of the anterior deltoid. You're looking at the mass of the deltoid, down towards the chest and down into the sternum. Then you come in from the side, and from the side, this is where we can look at the head carriage, and we're looking for this tragus over shoulder, over ball of the socket, down through the hip. So we're wanting, in an ideal world, we're wanting that alignment to be symmetrical, because that's the best carriage for our lordosis, to look at the head carriage and it not being forward. Obviously the head's forward, we're looking at this forward head carriage, which is not very efficient and often points to a muscle imbalance, along with these kind of generally medial irritated joints, like so. Then we go to the back and we're looking at the scapula, and we're looking at they fall about in line with about T2, and they're level. So when we look across the borders of the scapula, superior border here, we're looking that they're in line, and then we follow it down. Of course, you've got two apexes. We're looking for those apexes and looking whether they're level. So we're looking, are they level in this plane, or are they rotated or twisted? And we're just going to talk about that as we go. Don't need to do very long. You talk about it, but looking at it. Follow the spine down. And throughout all this, we're looking for any deformities, scars, because people often tell you, you examine them, you go, oh no, what's that? And they go, oh, I forgot to tell you I had a kidney transplant last week. And you go, oh, really? You've got pain around the lower back? Anyway, so we're following all this round. And then what we could do is we could do a functional test. So obviously if your patient's a impingement patient that's in agony, that can't sleep on his shoulder, which might be one, of course, you never know, then you're not going to get them to start doing press-ups, because they can't do press-ups. Okay, so if you know, in the real world, when an athlete comes in and say, well, in this kind of position I get pain, especially, then you might go and rig something up with a cable and get them to come into this position. But yeah, I can just feel it right there. That's where I feel it, right at the back of my shoulder, posterior impingement or something like that. So you're picking it up. But in this case, if the person is in a lot of pain, you're not going to do anything functional. If the patient's got very little pain, you say, oh, when I do a press-up, it's painful. You go, okay, do a press-up for me then. Do half a press-up on the bench. So we don't do a full press. Oh, that's where it is. It's right here. And so you can do something like that. So we've kind of gone through looking at someone, and we've gone through asking them whether doing something functional is appropriate. If it's appropriate, you can do it. And if it's not appropriate for them, too much pain, you just won't bother doing it. And that'll be fine. You just say, well, they're holding their arm like this, they've got an antalgic posture, they look like they're in pain, I'm not going to ask them to do anything until I've examined them. You know what, that's perfect. It's a perfect answer. Or actually, they look fine, they've got, you know, they don't look like they're in pain, press-up causes them pain, you go, show me press-up, do half a press-up, tell me where it is. And again, that's fine. But then we're going to look at looking at the neck. And what we're going to do is we're going to put the neck in this quadrant position. So the difference between a quadrant position and a Sperling's position is the difference is pressure. Okay, so I don't want to put pressure on the neck because I'm not doing a Sperling's. I am doing what's called a quadrant, which is all the movements together. Yeah, all the compressive movements together. However, if I say to somebody I'm examining, can I do a quadrant? Can you put your head in a quadrant position? They're going to go, what are you on about? And so you can't do that. So what you do is, well, I want you to look this way, mate. Tilt your head this way, and then so there's no pressure, but I'm just telling them this is what position I want their head in. Okay. So I'm clearing their cervical spine by doing that. But there isn't pressure which you put in on a Sperling's test. Make sense? Yeah? With me so far? Then we're going to look at clearing the elbow. And what we want to do with the elbow is up into flexion, full extension, a bit of overpressure, pronation, supination. Job done. We stop you, move on. So you've cleared the cervical spine with a quadrant position. You've cleared the elbow with flexion over pressure, extension over pressure, pronation, supination. That's it. We won't let you go any further than that. Cool. So when we look at ranges of motion now, obviously the key thing is here we're looking for quality of movement, whether the patient's in pain, and then whether they can achieve that movement comparative to right to left. So we're going to look at, if we get you to stand up, it's easiest. So I want you to bring both arms up like this for me, and then take both arms back and behind you. Brilliant, good. No problems there. No? All good.
No.
Good. Arms out to the side, and we're going to come up like so, up into abduction and down. Brilliant. We're going to do internal external rotation from neutral, which is neutral. So in and out. Good. And out all the way. Brilliant. And then we do a thing called a combination movement. So arm behind head is a combination of elevation and internal rotation. Arm behind back is extension and external rotation. Yeah? So we do arm behind head, arm behind back. And you just say that's a combination of different movements, and that's how we describe it. So scapular movements. So what we can do with the scapula then is to look at the scapula. Now, if we look at elevation of the scapula, that is elevation of the scapula, and that is depression of the scapula. The scapula moves up and down. So elevation, depression, and we look at that from behind. Okay? And then protraction is that, and retraction is that. Okay, so let's do that. So let's do elevation, good, and then down into depression, and then protraction, good, and then retraction. Brilliant. Any pain in that? Because obviously what you're doing is, remember that your scapula joins onto your glenoid, and your glenoid is your shoulder joint. So whatever happens here, the ball and socket is here. So this dictates where your shoulder is. So if my shoulder's here, straight away my glenohumeral joint is internally rotated. Straight away I'm in more of a position of impingement here than I am there. So whatever my scapula does, it's elevated, I'm elevating the glenohumeral. If it's protracted, I'm changing the dynamics of my shoulder. And that's important to us because people who tend to get a lot of shoulder pain tend to be a little bit like this. Fabulous. Okay, let's go down. So here we're looking at the, should I put all of them in? It's passive up there. Joe, can you come and alter this for me? Am I going to...
active range of motion.
Guys, do apologise. I'm going to have to show you that. So I just got talking as I normally do. Okay, so I failed my OSCE straight up with the light. Just go thoroughly get out of your dick. Right, okay, so flexion, forward flexion, I take him up, just relax for me, brilliant, good, and relax again, fabulous. So I tend to kind of put my hand on the shoulder because I want to feel whether it's cracking or clunking or whether it feels smooth or it doesn't feel smooth. And then obviously I can come out into abduction, brilliant, and then internal and external rotation, like so, fabulous. So I'm going to test in this position here. So what I want to do is, because Rob's a bit meaty lad, don't want a big fight with him, me trying to prove I'm stronger than him, although I very much am. What I want to do is, don't let me move you. Good lad. Okay, don't let me move you. Good boy. Don't let me move you. Brilliant. Back down to this position. Don't let me move you. And don't let me move you. Lesser man would have been flung across the room, wouldn't they? Okay, grab a seat. So palpation, you've got to start somewhere with this palpation. Again, it doesn't really matter, but a good place to start is your your sternoclavicular joint. Talked all afternoon, I'm done. And your sternoclavicular joint is where the end of the collarbone is here. A little disc in it that gets really sore. And I palpate out until I get to the ACJ, which is there. Acromioclavicular joint, and then I'm naturally on the acromion, so I might as well follow it. So sternoclavicular, clavicle, acromioclavicular, acromion, and then I'm back to the biceps tendon, and the biceps tendon sits in this bicipital groove at the front here. Always sore to touch on everybody, irrespective if we've got pathology or not. Across the kind of deltoid bulk, around the back of his shoulder, and I have the spine of his scapula. Is there a shoulder joint in the back there? is what we found earlier. So as I palpate from here, palpate across to this joint here, then the acromion. Don't show this on social media. Then the spine is here. So what muscle sits there? Infraspinatus. So if infraspinatus sits there, supraspinatus. Nice one. And so then I can work my way round through the deltoid, onto the spine, up onto supraspinatus, down onto infraspinatus. Does it say the inferior angle there? Yeah. Down across the border. Now, you've got on the spine, and you felt that muscle above, you felt the muscle below, and you've got this V shape. And we're just going to follow that lateral border down to the inferior pole, or the inferior angle of the scapula of the pole, that's the kneecap, and then I come up on the medial border, up through there. Yeah? And then you do exactly the same on the other side.
In the OSCE, do you do both sides?
You'll start on the other side, and we'll stop you on the other side because you don't have enough time. Okay, we won't let you unless we don't like you, in which case we'll just let you crack on. You'll be alright, don't worry. Anyway, go. So let's come to impingement test. So as Rob said correctly, impingement test, and you said, is a passive test. The problem with this in real world, and why you see us doing differently, and you'll see all the orthopods you ever go into clinic with doing differently, is because a patient doesn't know what an ears test is, and they don't know what you're doing. So in essence, what you stand up for. So what we do is you internally rotate, and you passively come up with a degree of overpressure at the top. But what you'll naturally see people doing is, I'm just going to turn it. Can you lift your arm up for me? Oh, that's so there. Okay, relax there. Just relax in there. Brilliant. I'm going to take you there. Yeah? Doesn't matter. Absolutely makes no difference. Okay? You might get them to do the first bit, or you might do all of it. And again, from us, there'll be no problem. And to be clinically, in the hospital or wherever you go, most people will do a combination of different things. So don't worry about that. Brilliant. So we've got Neer's test, and then we do Hawkins-Kennedy. Now, Hawkins-Kennedy test, you see, when I do it in clinic, don't follow me, but when I do it in clinic, I do this. Yeah, but if you see Hawkins-Kennedy test, you'll see most people come around. Ooh, hello. Ooh, what's that? It's not right, is it? Hawkins-Kennedy test. Anybody do it different to that?
Is there a reason?
Anybody want to do
why
it
you did
different to that?
Standing up instead of.
No, just so you can see. See the difference if you sit down, it's fine. If you want the patient to sit down, you've got more. If you're short,
They're going to be.
we'll get you a step. You can stand on a step, fine. Empty can sign, empty can test. Now, not to be confused with O'Brien's test. Okay, when I come to O'Brien's test, I'll tell you this. So we're in the scapular plane. The scapula is at this angle. So when you hear people talk about this, going to the scapular plane is this. We're very efficient in this plane here. And what we do is we put them in that plane, and we internally rotate to rotate the greater tuberosity tight into that space. And then what we're doing is, don't let me move you, don't let me move you. What we're doing then is, in essence, we're tightening up supraspinatus and shoving it in the roof of the acromion. So from a mechanical perspective, we're trying to oppose two bones in a sandwich with a tendon in the middle. That's the kind of reality of why we do it. So that's empty can test. Happy?
Can you show it?
Yeah. So kind of in this plane here, we bring him up. Don't let me move you. Don't let me move you. Yeah? And what we're doing is, obviously, excuse me, ooh, that sound right. Go. Happy? Happy with those? We should? Okay. Label tests. Now, a crank test, let's go with O'Brien's. So we just did an empty can test, and we said that it was in the line of the scapula, and the scapula comes out your chest wall like this, so that's where your shoulder joint really is. We put them in that position. Now, O'Brien's is all about looking at the labrum, okay? And here, we are winding up the long head biceps. Remember, the long head biceps is the top of our tinner tuna or our sardines, yeah? And when we rip the labrum off, we create a slap. The biceps pulls the top of the ring pull out, and that's what a slap lesion is. Okay, it's like opening a big tin of tuna or a big tin of sardines. You pull on the ring pull. The biceps is the ring pull going into the top of the labrum. Is there a picture of the labrum? Just Google it. I'm sure you're not on my search history. Just put long-head biceps, sardine tin. See what comes up. Oh, shit. So, long-headed biceps. So, this here, everybody see that? So put your head down. That's your labrum. This is your long-headed biceps. If I pull this, I open a can. Plantus peanuts from the top down. Get it? No? Not really? They don't get it. They don't get it, mate. So if I pull this ring pull down, it pulls the labrum off, and that's a slap. Superior, anterior, posterior labral tear, slap. That's the long head of biceps. It attaches at the top, and as it attaches, if you rag it, you pull the top down like you would, well, just like opening a tin. What? What's that? What's that thing there? Who needs one of them? Imagine going on the piss with that in your pocket. Is that when we get a bit more disabled? We're going to start having those kind of things. Oh, I'm going to have to find that picture now before I'm done. That's pissed me off. So knowing. Right. Okay. So think about this. Think about the labrum. So I know Brian's test. We wind up the long head of biceps. So we know the long head of biceps goes onto the labrum. If we pull the long head of biceps hard enough, we'll rip the labrum off. So we put it in a position like that, and then what we do is say, I want you to push up for me. And you go, oh, that's sore, that I can feel that, that's in my shoulder. Then we turn them round, get them to push up, and they don't have any pain, because what we've done is we've deloaded it. We've loaded it, unloaded it. Positive, and then negative. Does that make sense? Now a crank test, lay down on your side. Again, you'll see people do this in, just on your back, sorry. You'll see people doing this in different ways. But a crank test is a little bit like a cartilage test, because what you're doing is you're pushing in. I'm going to get his arm, this is his elbow, and this is his socket. And I'll push it in. I'm going to rotate it in and out. And of course, if it's not congruent and there's a little bit that's a problem, I'm going to catch it. Okay, so it looks something like this. I push in, and then I move the shoulder backwards and forwards.
So it's like screwing and
Like
into something. Like you push it in and then.
You'll see people do it standing up, and you'll see people doing it, sit up for a drop. I do it like that, and you'll see people doing it at a lower angle, like this. To be fair, it's internal and external rotation, small amount. It's a lot of internal, it's like a lot of compression. You'll find it really difficult with somebody like Rob, who's obviously quite a muscular lad. He needs to lay down because you're never going to control it. So pushing in, you need to get the angle to do it. Yeah? But if you did it in sitting and you pushed up and he was at 45 degrees, that'd be fine. But it's finding that point. Brilliant. I lay down and go for everybody. So now we're talking about instability. We're talking about dislocation. So think of the OSCE. This might say that this guy had a dislocation, went to A&E, and didn't go to A&E, but thought he dislocated his shoulder. And now you're thinking his shoulder's unstable. So 80% of all dislocations are here, in this position, where your shoulder will feel very, very unstable, because it's going to pop out. It's going to come this way. It's going to come out that way. For most dislocations, not all, but most. So what you want to do is you take very, very gingerly, you take him back They'll go, oh yeah, and they literally learn, no, I don't like that, don't take me there. I've had sort of physio dislocate somebody's shoulder in the treatment room, and they were screaming, this person was screaming the place out. I was like, what's going on, I've gone in, the shoulder's dislocated. I'm like,
This is my close up shoulder.
gotta be careful. So you take them, and you go, and you can feel that doesn't feel very steady, you can feel it moving around and plunking, and they don't like it. So what you're then going to do is you're going to come out and you're going to fix down on that. So this, in essence, you're stopping it from coming forward. So stopping this golf ball popping off the side of this tee forward. Then you take it back and people feel so much more comfortable with that. So you've got an apprehension, then a relocation. So the apprehension is taking them, I don't like that, come back out, pressure, take it again, relocation. Does that make sense? Sit off the foot. The next one is did you dislocate that?
Yeah, this one.
And what did you have? A putty clap? Did you have a capsule tightening surgery or what did you?
I can't remember what I had. I had a screw in the heel section.
It's not doing it on there then. So, you've got your acromion here, and we know that obviously a centred shoulder will be pretty centred with all these ligaments, tendons, everything in place. If the shoulder's unstable, you tend to get a bit of inferior instability. So as you pull down on his arm, I can get my thumb right in, and you see a sulcus. You see this. Yeah, just Google a sulcus sign. You can see a divot underneath your acromion. So like with Rob, you can't see it; it's continuous. But as you pull this right down, you can get your thumb in it because you're getting your thumb into the laxity. Yeah, there, mate. This one here. No, come off it. Where was it? Sorry. Go up a bit. I think there's a perfect picture. Here, look. Yeah.
Oh?
Yeah. You've got a gap. You can stick your thumb in it. And as you pull down, that gap opens and it creates a sulcus. And then you let go of it and you don't see the sulcus so much.
Do you have to fix the shoulder?
So you in essence, you start by kind of pulling down. And obviously, once I pull down and create a sulcus, I could put my thumb in it, but you can see it. So you see it. So you pull down to see it like that. Cool. Happy? Okay. So speeds test.
Load shift.
Oh, sorry. Load shift. Load shift is you're fixing the shoulder, the scapula, or the acromion, and you're getting the humeral head, and you're translating the humeral head. And I had somebody the other day, and it was frightening how much this thing moved compared to the other, and I was like, I just need to be really, really careful there because it was just so baggy. So basically, what you're doing is you're getting the head, fixing and pushing backwards and forwards. That's a bit lax, isn't it? A little bit laxity. I'm doing that. And I'm going to do the shoulder and I'm comparing, looking at laxity. And obviously we're looking for joint capsule and ligament laxity of the shoulder. With me so far? Yeah. Speeds test. So speeds test is pretty much nice straight arm, put my thumb over the long head of biceps, and I just want you to raise your arm up towards the ceiling for me. So obviously long head of biceps is a flexor as well as being the strongest supinator we have in our body. Yeah? So we're trying to lift up like this. And Jurgensen's is we're going to get in, just relax there for me, breathe. I'm going to put my hand on here, and what I'm feeling and looking for is subluxation. So your biceps goes in the long head of biceps goes in the bicipital groove. It has a transverse humeral ligament. So it goes in a groove and it's pinned down by this big strong ligament that stops it coming out, stops it going in and out. Okay? And what you're looking for is any pathology around that. And so we're grabbing someone, and we know that obviously the biceps, because it attaches right under there, it does this. And so what we're trying to do is get him to supinate for me to turn up. Pain, any difference in power, and any feeling of subluxation further up.
If on imaging we have no damages to the shoulder, but still happens, do you know why that can happen?
If you, so the question is, if if you did that and it subluxed and everything on the MRI was normal, have you had an ultrasound scan? Because obviously when you dynamically, so when we scan these on an ultrasound, it's real time. So if you lay in an MRI scanner, you're not moving at all, so you're getting a static picture. But as you do it on an ultrasound, if it's going to come out, you can see it come out. Or if you internal and external rotation, you can see it coming in and out.
Yeah, I've had both.
Oh.
But with the ultrasound, it said you could see the tendon just on the edge, about to come out. But we didn't force it.
Yeah.
But
It might sublux though and go back in. You see, it might if it moves. If it's not, I mean, the argument would be if it's in this place, right, and it shouldn't move at all, it should be snug, and it's moving 4 mil either way, it's going to rag the tendon to bits, isn't it, over a period of time? It's going to make the tendon so sore. So whether it comes right out or it moves around, it shouldn't.
Yeah, this is what happens to me. Like, but they said they can't do anything until they look inside.
Yeah.
Because they don't know why it's happening. Because the image is flipped. And that's pain. Like, just happen.
Yeah. The problem with the shoulder is it's
Wondering why. Like,
it must be moving, mustn't it? It
Yeah.
must be popping out, or it must be moving, and it's rubbing. You know, getting a tendon rubbing across something all day is not going to be good for that tendon, is it? And your shoulder is so unstable. Shoulders are so unstable, like they're shit. The ligaments are so crap. And so if you've had loads of shoulder operations, the timing of your shoulder control will be so poor, comparative.
yeah.
Getting it back is. You need to see my mate. My mate's called Ben Ashworth. Google him, and he's doing a PhD in shoulder stuff, and he's a physio who's. I worked with the Olympics for like 8 years, and he's a really good lad. And he is like a pioneer of lots of stability stuff. But he's so much hard work to get shoulders right. The hardest work ever to get shoulder. You know, everything else gets better, but the shoulders don't.
It's got a clinic up the road, I think.
Yeah, I emailed him a year ago, but he just sent me to Gus. And
Oh, did it?
Gus just
Alright, well, he's my mate. I'll ask him. I'll ask him.
yeah. Annoying for me. Like, he was just telling me to do the same exercise and every time.
Yeah, you need to go and see him properly.
Yeah.
Yeah, I'll email him.
You know, so if an introduced disability, would you just say,
So you say that this person, if I was to take Rob back and he'd go, well, you know, and I feel that this is really translating under my hand, then he has got a positive apprehension test that is corrected by a relocation test.
so what's slightly different about that?
Shoulder instability.
Okay, just shoulder.
But you know, this is why we do lots of different tests, because as we said, that some of the specificity, accuracy, and reliability is really poor. So you do lots of tests to try and negate the poorness of those tests. You know, so it's history, it's movement, it's multiple tests. It's not as simple as like one test catches that, and so therefore that's 100%. So you're looking at history, you're looking at movement patterns, you're looking at loads of different things, and we do 3-4 tests of each one because we know that they on their own they're not very good. But it's the best we've got. And people go, well, they're rubbish, and it's like, well, think of something better because I can't think of something better. Right. Okay. So if you've got someone who can't put their hand behind the back, and there are plenty of people who are really in a lot of pain can't do this, what you're going to ask someone to do is to push in against their tummy. The subscapularis does this. So pushing against the tummy obviously makes subscapularis work. If they can get their hand behind the back, an optimal test, it's much more optimal if you read the research, is a Gerder's lift-off test. So 2 ways of doing this. You'll see some people just ask, just push it out my way, buddy. There. But most people get them to push against them. Now, I don't know why. You know, the test says just come off your back, a lift-off test. But most clinicians say push against that. And I've always done it, and I don't know why really. Just because I like it. Right, so that's those two. A scarf test I think is self-explanatory. We're coming across, and what we're doing is getting the acromion, getting the clavicular, the ligaments are obviously maybe damaged, and we're opposing the joint, poisoning the soft tissues, and often that is really, really painful. Great. Okay, so internal rotation flag is when we rotate, we hold the shoulder up here, we want now, I need you to keep that there, Don't let it drop. Don't let it leave it. So what we're doing is we're basically getting them to internally rotate and use supraspinatus to hold her arm there and the cuff. If they can't hold it there, if they come out of that rotation, so that's one way to do it. Can I show you the other way, which is the most common? And the other way is to take them here. So you'll see some people doing like a NIAS test, but the best way to do external rotation lag sign is take them here, hold that there. Now if he comes from here to there, then he isn't holding that back. So I expect him never to move. So if I say to you hold that there and he can't, and his arm comes to here, he doesn't have external rotation control. But you will see people in this position like a NIAS test, okay? I want you to focus on this one where we're rotating. Stay there, don't let him move. Good lad. When he drops forward, when he can't control that position, he doesn't have rotation control, okay, which is part of the cuff.
Do you look for compensation in that? Because I know
Yeah,
like, to
of
do
course,
that,
of
I'm
course.
like,
Yeah.
I arch my back to
Yeah.
keep my arm up.
Yeah, or you elevate your shoulder, yeah. Of course you look for that. So it's there and you're looking at how that's achieved. Again, at this level it's difficult because there's loads of things that we look at that are a bit more, but from a test perspective, just say are they compensating, but you've got enough to remember, I think, but yeah, is the answer to that question. Okay, drop arm test is you bring them up and you say, I want you to hold your arm there, and you don't let them just drop it. You kind of bring your arm away and you see whether they've got control of it. To be fair, all the complete cuff ruptures I see, and I probably see one every 2 weeks, the best thing is you know straight away because you push them there and they're here. And they're going, go on, you go, push me. And you go, he goes, I am. He's like, you know what? I am. And most of the cuff tears I get are 60, 70-year-old guys, had a bit of shoulder pain, and then just fell. And the humeral head's gone into the acromion and just nipped off the supraspinatus and completely ruptured it. And you know straight away when they're there, and you go, push out, and you go, I am pushing out, I am. And you go, you know what? And you scan it, and you go, it's gone. There's nothing there, there's a big backward scan. Which is always, it's satisfying for us because it's easy, really easy diagnosis, but not so good for the bloke who's got it. So, have we done Gilmer's lift off test twice?
Yeah, you've got it in there. Lift off there.
Oh, for some scan. Okay, no, you don't need to do that again. Cool. What are we doing for time? Happy?
So, was the drop arm test to a sign like that?
Drop arm tests up like this. External rotation lag sign is there. Drop arm is here.
You know what you said about how we don't have time to do it on both sides?
Yeah, we want you